So, I'm ready to go whenever you are.
Okay, sir. It's okay. You can start now.
So we'll start sharing.
Yes, sir.
Oh,
I have a humble request to all. Everyone, please put on your video. Those who are not ready to put on your video won't get your attendance from this class onwards. It's necessary to put on your video. Please do it.
can you hear me?
Yes, sir. We can hear you.
Okay. So one thing that I would like to tell that today, unfortunately, I have to present my case on my mobile phone because I could not get hold of my laptop today. So there is a possibility I might get some call in between. At that point of time, this may get disrupted. So I hope the calls will be minimum because, and as I said, today's session is on mobile phone. So we'll start. Today we are doing part one of communication skills, and the basics of any communication skills is active listening. That's why today we are going to talk about active listening. So, but why are we learning communication to begin with? Because patient satisfaction is the most important thing when it comes to any service. Not just healthcare service, you talk about business management or tourism or any other area which deals with the service industry, the client satisfaction, in our case, the patient and family, their satisfaction is what is most important. And there was a study done in the 80s, which was about headache. It came in the headache journal. Uh, and what they found was if the patient got this experience that in the first visit itself, uh, the doctor listened to their problems properly, a lot of the headache problems were taken care of just with that. So this idea that I have been listened to, somebody listened to my problem, that is a very, very powerful therapy in itself. Because when I feel satisfied, that leads to better outcome for me as the patient and for you as the healthcare provider. And this is the importance of communication skills. Along with it, a lot of errors occur because of poor communication, miscommunication, inadequate communication, or lack of communication, anywhere in the range of 60 to 70%, and most of them are preventable. Apart from that, this healthcare patient and family relationship is very dynamic. For example, if you are better able to get a good history, not just a superficial history, but a much more deep history, I think there is some background noise distraction.
Sir, it's
Hello?
okay now. Hello, sir.
Oh, right.
Okay, sir.
So if there is, if the history taking is better, your diagnostic accuracy will improve. And good history taking depends on good communication skills. So if your diagnosis is better, then your treatment management also becomes better. But what if the patient is not compliant to your treatment. So for better patient compliance, better communication is required. And with good communication, if the patient compliance to your treatment or care improves, then naturally the clinical outcome will be good. For example, if you tell them why it is important to do regular dressing of a pressure sore, so you can teach them, but if they don't understand the importance or they don't know how to do it, if their compliance is poor, then no matter how good a nurse you are, that pressure sore is not going to get taken care of. Of course, while the patient is in the hospital, you can do a good job. But what happens when the patient goes home? So, if you have communicated it properly, they understand why it is important to do the dressing daily. They understand the importance of doing it the right way. And if you have communicated and taught them well, then the compliance will be there and the clinical outcome will be good. If the clinical outcome is good, the patient and family satisfaction will be good. You will have a happy patient and family. And if the patient is happy, then you and your team will be happy. On the other side of the patient and family are not happy, they are always complaining, your stress level and your team's stress level will also increase. So just knowing, having the knowledge and skill from your end will not achieve that. Having good communication, ability to convey the message to the intended person or people, that is important. And if you are having a happy team because you have a happy patient and family, naturally your stress levels will be less. This also has an implication on patient safety, as I had mentioned earlier in the previous slides. So good communication will reduce errors, medical errors, and naturally it will enhance patient safety. And if the patient is safe, there are less errors, your chance of litigation or even physical violence or physical abuse, all of these things will also come down. And hence, communication has a multi-dimensional effect. Good communication skills is very, very important in all domains of health. So what is the secret ingredient for good communication? What is the foundation of good communication? What is the basic requirement for good communication? That is active listening. The word active means it is not passive listening. Just sitting and listening is not active listening. Active listening is a very, very dynamic process. And today we are here to learn about that. So when it comes to active listening, we will divide it into two parts. One is the body language and second part is the verbal part. Why it is important to learn body language? Because often we are ourselves not aware of how our body is reacting when we are having a conversation with our patients or their families, or for that matter, with anybody. Most of the time, we are just concentrating on what we are saying. We are not concentrating on how we are saying what we are saying. What is the tone of our voice? What is the facial expression? How is your body positioned? What is the posture of your body? All of these things convey messages. Your body talks while you are verbally talking. And it is very important to enhance your body language for better outcomes. So this is one reason that we have to learn body language. Of course, today we cannot learn body language in today's session in its entirety. It is like a large ocean, and you can spend a lifetime learning about body language. Still, we will never finish learning. So today's session, we will talk about a few things which will help us in our day-to-day clinical practice. Another reason why we should learn body language is because body language is the major component of any communication. So this Albert Mehrabian model conveys that on an average, spoken words takes up around 7% of communication. The voice and tone takes up around 38%, and rest of the body language takes about 55%. So if you take it in totality, the verbal part is 7% and almost 93% is body language. That is why it is important to learn body language. Now, as I said today, we will not be able to cover everything. It's a large ocean, but I'll just talk about around 6, 7 points, which will be helpful to us in our day-to-day clinical practice. And hopefully, you will become interested to learn more about it. Go to Google, check on body language for nurses, body language for healthcare professionals, and see there's a lot of information out there. Just go through it, and gradually, as you learn more about body language, you will get better and better in communication skills. Remember, this is the major part of communication. It is also the universal part of communication. You can communicate by body language to anybody on earth, irrespective of language or any other barriers. You can communicate with your body. So first and foremost, eye contact is very important. If you are a nurse sitting in the nursing station looking at the computer and somebody comes and talks to you, and if you don't make eye contact, you're just communicating with that person while focusing on the computer, that is going to create a very bad image. It is very important to look up, make eye contact, and talk to that person. This applies to whether you are going to the patient's room for any purpose, or the family is coming to the nursing station to talk to you, or if you're a doctor, the patient or family has come to meet you in the OP, or you're going to the IP, or if you're a physiotherapist seeing the patient or family, or if you're the pharmacist, or if you're the person who brings the food, or you're from administration and came to discuss about the billing. Whoever you are, if you are involved in healthcare industry, healthcare profession, when you talk to patient and family, make eye contact, because when you make eye contact, that is the start of a relationship, and relationship we have to improve so that we can achieve all that we talked about before. Smile is very important, but remember, our natural smile comes only when we see somebody whom we know or like. The professional smile is something that we have to practice. It doesn't come natural. So it is a skill, just like taking blood pressure or taking temperature or checking the pulse. It is a skill that we have to learn. It doesn't come naturally. So we have to practice it among ourselves. So next time you go to your hospital or clinic, try smiling at your colleagues, not necessarily your friends, but you people that to whom you usually do not smile. You try practicing smiling at them. The security person, the cleaning staff, the food and beverages staff, your fellow nurses, physiotherapists, pharmacists, doctors. Try, think, and practice smiling. This is important not because you want to make them happy, because you want to get the skill so that you become so good at it that you will have a smile whenever you somebody, whether you know the person or not. It takes practice. Please remember that professional smile does not come naturally. You have to practice it. And when you smile, it can be felt by the person in front of you. whether you have a mask or a PPT kit, because your smile, despite the mask or a full PPE, your smile can be seen in your eyes and it can be heard in your voice. Remember this. Your smile can be seen in your eyes and it can be heard in your voice. Therefore, it is very important to smile, and professional smile comes only with practice. Natural smile comes to us when we see people we like, we know, and those whom we are acquainted. It does not come naturally. The professional smile has to be practiced. Now, if you take that effort to practice and gain the skill of professional smile, you will have a good tone of voice without any effort. Because with a smiling face, it is impossible to have a bad tone of voice. You cannot have a bad tone of voice when you have a smile on your face. You can have a bad tone of voice with a grumpy facial expression, but you cannot have a bad tone of voice with a smiling face. Your voice will automatically become good. Therefore, if you practice professional smile, I guarantee you your tone of voice will improve. So when you go to the store, you buy one, you get something free. Similarly, this is an offer. You practice professional smile and you will get a good tone of voice free. Now, another important thing is how you position yourself in relation to the patient that you are seeing or anybody. But we are in the healthcare profession, so we will talk about uh, our how we position our body in relation to the patient. You can see in the pictures on your screen. Let us focus on the upper picture on the left side, where you see a healthcare professional standing by the bedside of the patient. You can see the patient is looking at the healthcare professional and the healthcare professional is looking at the patient. Eye contact is there. Probably there is a smile also. But if you notice, the patient has to turn his head to make this eye contact. And this will become uncomfortable within a few moments. Therefore, for comfortable eye contact, it is best if we position ourselves nearer to the foot end of the patient. You may have to go near the patient for any particular purpose, let's say for checking BP or giving an injection or something like that. But to begin with, when you come into the room and say, good morning, how are you? Those kind of initial part, if you can position yourself near to the foot end of the patient, then it will be comfortable for the patient to make eye contact. The person does not have to turn the head and strain the neck to make eye contact with you. So always start near the foot end of the patient so that there is a comfortable eye contact and a communication. You can see in the picture on the right side, upper picture on the right side, where you can see a healthcare professional sitting near the foot end of the patient. Here also the patient is lying down, but you can see the patient can comfortably make eye contact with the healthcare professional who's sitting near the foot end of the patient. So you can clearly see the difference when you position yourself near the foot end of the patient. Now, you can also see the difference that one professional is standing, which is on the left side upper picture, and you can see another healthcare professional sitting, which is on the right side upper picture. Always remember You increase satisfaction by bringing your body down. That is, if you sit and talk, you increase satisfaction. So you can take a BP while sitting down, you can put a cannula while sitting down, you can, whatever you can do, which you can do by sitting by the bedside of the patient, that interaction will be more satisfactory to the patient and the family compared to you standing and interacting. This is, if you can imagine, if some guest come into your house, they come and they talk to you, they stand, but they do not sit down. You give them tea and snacks, they drink the tea standing. They don't sit down. And after half an hour of standing, talking, enjoying the tea, they walk away, they go. Would you be satisfied? Instead of that, if they come and sit down, talk to you, you give them tea, they have it all sitting down, then they go, that will be more satisfactory. The same thing. It is psychological that when you sit down and talk, you give more satisfaction rather than when you stand and talk. Don't spend more time. If your interaction time with the patient is 2 minutes or 1 minute in the room, if you spend that 1 minute sitting down and interacting, you will give more satisfaction. There will be some procedure for which you need to stand. Of course, you do it. But if you can sit and spend time talking or doing something, then ideally that will be better. So put yourself near the foot end of the patient and as much as possible sit down and interact with the patient. You can see the picture below. You have a healthcare professional at the bedside of a child, and obviously you can see the person is at the knee, bending at the knee, not bending at the hip. Most of the time when we interact with children, we look down at them from a height because children are small in size and we adults are bigger in size. We interact with them, we look down at them, and that is not going to be satisfactory. Most of the time, the children will get scared as well. So if you want to build up a relationship with children, not to scare them, become their friends, put yourself at their eye level. For those who can't bend and be at the knee level, the simplest thing will be to pull up a chair or a stool and sit down so that you can be at eye level with the child. So whether it's an adult or a child, making eye contact at eye level will be more satisfactory. And that is the reason why we say sit down and interact rather than standing and interact. When you stand and make eye contact, you are making that eye contact from a higher position and you are looking down at the person. So instead of that, if you sit down, you are making the eye contact at equal level. So you are creating equality, physical equality between you and the patient. And that increases satisfaction. That is the psychology behind it. Now, another important thing is body posture. You can see that one person is leaning back on the chair. It seems he is not interested in talking. It may seem he is arrogant. Whereas if you look at the right side picture, there is this lady leaning forward. It seems that she is willing to talk to you, willing to listen to you. So that is the difference that body posture makes. If you are sitting in lordosis, that is if your back is touching your chair, rest assured the body language is not satisfactory. Whereas if you are sitting with a slight kyphosis, slightly bent forward, you are showing with your body that I am here to listen to you. that body language is conveyed and understood by the person in front of you, irrespective of language barrier or any other barriers. That is why it is very important to learn body language. Your body will convey a lot of positive energy. These are some of the examples of leaning forward in healthcare industry. This is how we can sit and communicate with our patients and their families. Another area is respecting the body space. We have space bubbles around us. For example, from our body, from our skin to about 1 or 2 feet, it's an intimate space. We will willingly allow only those with whom we are intimate. It can be our children, our spouse, very close friends, or very close relatives, not everybody. And then there is the social space, that is the space with which we interact with others with whom we are socially acquainted. And beyond that is the public space. That is the space we interact with strangers with whom we don't know. However, we know there can be situations where we have to come close, physically close to people with whom we are not socially acquainted or even intimate. For example, if you're traveling in a public bus or a train which is very crowded, you are together with strangers with whom you don't know. And as a result, it is natural to feel little uncomfortable, to feel little stressed. Same thing happens if you are in a crowded lift. So you naturally you will try to reduce your body size by bringing your arms closer to your body or crossing your arms in front of your chest so that somebody does not stand very close to you. So these are some of the protective mechanisms in body language that we adopt when we become uncomfortable, when we are in close physical proximity with a stranger, because they are intruding into our intimate space or social space, and that can be distressing. Now, why am I saying this? Because in healthcare industry, the patient and the family members, they are strangers to us. We are neither their relatives or close friends. But because of our profession, we have to come very close to them, intrude into their social space, and often we have to intrude into their intimate space. We have to touch them as part of examining. We have to touch them as in a procedure. If you want to put in a cannula or check a BP or put in a catheter, so we have to interact with them in very close proximity. Now you can say that there is an implied consent. They came to us. They came to us with because they were sick or because they had some problems, medical problems, and naturally they know that we will have to interact with them in close proximity. They know that. However, the discomfort of being in of somebody intruding into our personal space or intimate space is an emotional discomfort. So at the brain level, we understand, the patient understands, but at the heart level, it is still uncomfortable. Therefore, we as healthcare professionals need to understand that we may be causing some level of discomfort to our patients when we interact with them. That doesn't mean we should stop interacting with them. Of course, we have to, but we have to understand that it will cause distress to the patient. Just imagine if somebody whom you don't know were to come very close to you and touch you, it will cause discomfort, right? It's the same thing. Therefore, what is the solution? Therefore, we have to tell them what we are going to do before we actually do. For example, if you are going to put a step on their chest, tell them, I'm going to examine you. Only then put. Don't put or don't touch them without telling them what you're going to do. If you're going to put in a cannula, tell them, I'm going to put this cannula. It might hurt a bit. Or if you're going to check BP, tell them, I'm going to check your BP. So it gives them that that small brief moment is enough for them to adjust to what is going to happen to them. If it is a procedure, explain to them about the procedure in a simple language that they understand. And while you are doing it, do a running commentary. Now I'm going to put betadine to clean this area of skin. You will feel a little wet. Okay, now the betadine cleaning is over. Now I'm going to put a cloth, a towel over you. Okay, and now I'm loading a syringe of local anesthetic, and I'm going to give you the local anesthetic. It will uh, feel like a small pinch. Okay, I'm giving you the local anesthetic. Now I'm going to wait for 30 seconds because I want the local anesthetic to start its effect. Okay, now 30 seconds is over. Now I'm going to put in a needle there to drain out the fluid. So something like that, a running commentary while you are doing it. So this will keep the patient informed about what is happening, and that way you can reduce a lot of distress that and uncertainty and distress that you may be causing to the patient. So the best way of respecting somebody is to respect their body space and reduce the emotional trauma by forewarning them, by telling them that you're going to touch or you're going to do this, so that they are able to adjust themselves accordingly. Now there are two examples over here. One on the right side, you have this healthcare professional aggressively looking into turning into the patient on the chair, and you can see the person pushing back as much as possible, because this picture very clearly shows that the patient sitting is feeling uncomfortable by the intrusion into the space. And look at the picture on the right side. You have the palliative nurse during home care sitting with a patient. All the things that you have learned in body language, you can see in that one picture. You have eye contact at eye level because both are sitting, not some somebody standing, another person sitting. It is both sitting. So eye level is same. So there is eye contact, comfortable eye contact. There is smile on the face. This is pre-COVID picture. But even if it is we are wearing a mask, still the smile is easily seen. And then you have the body position. Both people are sitting. And then you have the body posture. There is a slight posture in from both sides, a slight kyphosis from both sides. And there is a comfortable distance between the two of them. Their body language shows how comfortable they are with each other. So this is what we are aiming for. And don't forget the importance of human touch. And when I say human touch, I'm not talking about touching them with a step, or touching them when taking BP, or touching them when putting in a cannula. I'm not talking about procedural touch. I'm talking about human touch. When we are having a communication, touching somebody on the shoulder or on the arm, that is very important. So whether you are a doctor or a nurse or a physiotherapist, whoever you are, if you are interacting with patient and family, always make sure a human touch is there when you are communicating. That does not mean you go around touching everybody all the time. It has to be situation appropriate, but where the situation calls for it, don't forget the human touch. And because of COVID, we are all very conscious of hygiene and things like that. So initially in 2020, when we did not know much about COVID, we were all scared. I had stopped touching my patients altogether, and for 1 year it was like that. But by 2021, beginning of 2021, we were all, much more informed, much more aware of what to do, what not to do. So again, restarted the human touch. But after touching them, even, I mean, when I say touching, not for any procedure, just for the interaction part. If when I'm leaving a patient, just giving my hand for a handshake, that is very important. So if you have a patient who is getting discharged from your nursing station, when they are going, give a handshake, wish them well, tell them, don't, we wish that you don't have to come back soon. So something like that. But that human touch is very important. You can then sanitize your hands soon after that, right in front of the patient. Everybody understands, they don't mind. But please don't forget the human touch. Coming to some verbal do's and don'ts, many times we see doctors and nurses asking the patient or the family members questions in a leading manner. You're getting better now, isn't it? Your pain is getting better, isn't it? Everything, you are now fine, isn't it? So when you ask questions like that in that tone, they will find it very difficult to say, no, I'm not better. No, I still don't have pain. They will not be able to say that. Many of them will not be able to say that. Of course, some very empowered person, some of them come from very empowered socioeconomic background. They may be able to contradict you and say, no, 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 I'm not better. But most people will find it very difficult to say no when you're asking, you're better now, isn't it? So always ask question in an open-ended question. How are you today? And then they will be able to tell you all their problems because you have given them an opportunity by asking in an open-ended question rather than a leading question. So when it comes to verbal part, how you frame the question is very important. Never ask a leading question. Always ask an open-ended question. How are you today? What was the problem? Where are you having that problem? When does it come? Why do you think this happened? Those kind of words are very important. How, what, when, where, why, who. So when you frame questions using these kind of words, you are likely to be asking an open-ended question, something and in a tone which is neutral so that they don't feel pressured to give an answer that you want to hear. They will be able to, they'll be free to give an answer that is really what is bothering them. Another thing is when you are interacting with people, never minimize their problem. If you are having a severe toothache, for you, that is the biggest problem in the world. You, because your toothache is so bad. You can't eat anything, you can't drink anything, you can't think anything, you can't do anything, you can't work, you can't sleep. So for you, your problem is the biggest problem. And if somebody were to say, oh, wow, this is after all only a toothache, why are you creating such a song and dance about it? You are not likely to like that person. You will not at all be satisfied with that person who minimizes your problem. For you, it is a big deal. Also, never compare somebody's problem with something else. If that person were to say, oh, it is only a toothache, look, there are children dying of cancer in the cancer ward. When you are suffering from toothache, you don't care. There are children dying of cancer in cancer ward because for you, you are suffering because of your toothache. So if somebody were to tell you that your problem is nothing compared to somebody else's problem, you are not going to be satisfied with that person. So similarly, if you are the healthcare provider, when somebody comes and tells you their problems, never minimize their problems and never compare their problems with somebody else's problem. And what do you need to do instead? You should acknowledge. Instead of minimizing their problem, you should acknowledge. Yeah, anybody in your position, would be this way. I accept. I understand. I believe you. So acknowledging is very important. And if you normalize the patient's emotional experience of the distress, considering what you're going through, it's normal to feel this. Considering the toothache you have, I accept that you are having severe pain, and anybody in your position would be feeling this way. Instead of making you feel as if it is a small thing, instead of making you feel as some other people have some bigger problems than you, if somebody were to acknowledge your distress and tell you that how you are behaving is perfectly okay, because anybody in your position would be behaving like this, you are more likely to like that person, you are more likely to trust that person, you are more likely to listen to that person, because now you feel that person understands you, that person understands your suffering. So this is what we gain in terms of relationship, in terms of trust, in terms of good uh, relationship with the patient and family when we acknowledge their suffering and normalize their emotional experience. We do not normalize their problem. We don't tell them your problem is normal. We normalize their experience of the problem. I hope you understood the difference. If you have any questions on that later, I'll be happy to answer. Never give false hopes. Never say, don't worry, everything will be all right. These are the cliche. You push a button and a hope statement comes out. Don't worry, we are there with you. Don't worry, God will take care of the problem. Don't worry, we are all there with you. This kind of statements are never going to be full. Always give realistic hope. And to give realistic hope, you need to find out what the problem is. And many a times you may not have a solution. If you don't have a solution, listening to them, the active listening, using body language, the verbal do's and don'ts, that itself becomes a therapy. If you don't have a solution, listening to them will reduce their emotional burden. Just like you do an ascitic tapping, you tap and you allow the fluid to flow down and the abdomen gets comfortable. Similarly, when somebody is emotionally distressed, you sit and listen to them. They talk, they ventilate, and their distress gradually comes down. You may not have a solution to their problem, but you definitely know how to heal them by active listening. Active listening is a psychotherapy. It allows them to ventilate their emotional distress, just like you can do a ascitic tapping. So this is basically a psychological tapping, active listening for somebody who is distressed. Of course, if you have a solution to the problem, please give the solution. But if you don't, remember that is still not a hopeless situation. You can still provide them psychological relief by allowing them to ventilate. And there is no situation which is totally hopeless. For example, in my day-to-day practice, I see patients who are terminally ill. The patient has been sent to me by the oncologist or the pulmonologist or the neurologist or the physician because they have no further disease modifying treatment available. The patient does not have any more disease treatment available. So I tell them that, see, your disease treating doctors who are the experts in your disease, they have said that no further treatment is possible. And that means what we can still do is keep you comfortable as long as you need it. So that is conveying something that even if your disease is not curable, you can still be comfortable. And as long as needed, that means I am not going to ever tell you you don't have to come to me again. What that means is I am conveying without saying it, I'm conveying I will never abandon you. I will never abandon you. You can always come to me. You can always come to me. I will make sure that you are comfortable. So even if the disease cannot be cured, even if the patient is dying, we can always realistically provide comfort. So if you are able to provide physical comfort, then the next thing that you can target is emotional peace of mind. So physical comfort, peace of mind, and dignity of life. These are things you can aim for even if the disease is incurable, progressive, and advanced. So there is nothing like unrealistic hope. You should never give unrealistic hope. You should always give realistic hope. Very important thing, do not assume. Because if you assume, you make an ass of you and me. ASS, you and me. So do not assume because we get into all kinds of problems when you assume things. So whenever somebody is saying, I'm so scared, I'm so worried, I don't know what to do, how long I'm going to die, how long I'm going to live, am I going to die, sister, am I going to die, doctor? Ask them, why do you say that? Ask them, and then they will tell you why they said what they said. I'm so scared. Why are you scared? Could you tell me? What are you scared about? Would you like to talk about that? So it is very important to ask. Do not assume. Just because somebody says something, that does not mean that the reason they say it is what you think it. The simple way to not get into trouble is ask them. Ask them and they will tell you why they said what they said. So some of the last few slides. So how do we take history? I'm sure that all of you know how to take history, but this is history taking, adding active listening components. First and foremost, greeting, make eye contact, smile, nod your head, and say what is culturally appropriate in your area. Then next step is get comfortable. If you are sitting in your OP as a doctor or you're sitting in your nursing station and somebody has come to talk to you, and if it is something for potentially for something long, you can offer them a chair or a stool or some place to sit down. If you do not have a chair or a stool to offer them, then you also stand up. The idea is to keep the body position equal. And if you have gone to the patient's room uh, as part of IP or home care, Sit down. You make yourself comfortable by pulling up a chair or a stool and sit down by the bedside of the patient, preferably near the foot end of the patient. Then you can start the interview with an open-ended question. How may I help you? What brings you here today? Or if you have gone to them, you can ask, how are you today? Of course, in your own language. And once you have asked open-ended question, then listen. Do not interrupt. There are plenty of studies which shows that medical professionals, especially doctors, interrupt the patient within the first 15 seconds, usually by the 8th or 11th second. And it is very important not to interrupt and listen. And not only is that enough, you have to encourage the patient to take by maintaining eye contact, nodding your head from time to time, and making encouraging sounds like, okay, go on. So all of these things are very important to encourage the patient to talk. Otherwise, if you just sit silently and stare at them, then they will feel very uncomfortable. They would not know whether to continue or not. So encourage them. If you did not understand anything what they said, then clarify it at that same point. Don't wait for the end part. So clarify as you go along. What did you say that? I did not understand. Can you repeat what you just said? I didn't hear it properly. So it is very important to clarify. Also, while you're doing this, try to understand their insight. What do they understand about the situation? Asking questions like, what have they told you? What do you think is going on? What are the results of the test that you had done? Did somebody tell you? Do you know what the results are? So all of these kind of questions are very important. We should have a clarity on what is their insight. What do they know about what is happening to them? Also, we have to find out what are they worried about? What are their concerns? What are their priorities? Why did they come to us? What do they hope to get out of us? So it is very important to also find out their concerns, their goals, and what they are looking. And once you have information that you have to share with them honestly. Now it is possible, especially in our culture, where sometimes families do not want us to share information with the patient. There's those barriers we'll have to deal with, but not today. That is for the next session in communication skills part 2, but not today. So those barriers we need to overcome to share information with the patient honestly. It is also important to share information in a language that the patient understands. If you use medical jargon, which is Greek and Latin, they will not understand it. They may sit in front of you and shake their head. But afterwards, when you ask them, what did you understand? They will say, I did not understand anything. So you have to convey. For example, if you say the USG showed a cyst in the ovary, don't worry. From their point of view, they paid the bill for scan of the abdomen, and you have told them that they have done this test called USG. So they say, oh, the test was wrong. They paid for something and they did the wrong test. We paid for scan of abdomen. They did a test called USG. So communication problem started there. And they said they think that cyst in the ovary. Cyst means cancer. From your point of view, you are just trying to convey it is something very benign. But They may think that cyst is cancer, and then they say, "Oh, there's something very serious going on." And then you said, "Don't not to worry." So from their point of view, why are they saying not to worry when there is something very serious going on? Total confusion. So instead of that, instead of saying USG should assist in the ovary, don't worry, you could have said in simple language, the scan that was done showed a small swelling in the ovary, which we believe is something very simple and nothing to worry about. So instead of saying USG, which is a technical term, which is a jargon, which we all understand, we being healthcare professionals, but it's not necessary that people, the non-medical professionals may not understand. Instead of saying cyst, if you can just say small swelling, that will be easily understood by people. And then telling them that we believe it is nothing serious will convey the idea. It's very important to share information in simple language. And after you have shared information, then you can discuss how to go about it. What are the treatment options? Remember, when we're discussing treatment options, don't behave like a waiter in a hotel. We have option one, two, three, four, five. Choose. No, you have to guide them on what is the best option, what is the second best option, what are the pros and cons of various things. Remember, you can be an expert only on the medical part of it. At least that you should convey in a proper format for them to understand about the various aspects of it. Again, in a language that they understand. What you are not an expert on is their life, their problems, their financial consider problems, their other problems. There is nobody to come and stay in the hospital, or their inter-family problems. You are not an expert on that. They are experts on that part. So you have to take into account whether the treatment option that you have suggested is it practical for them. So you can't say that you have to choose the best treatment option or the best management option that you are suggesting. You have to wait and ask them whether it is possible for them to proceed with it. Because they have their beliefs, they have their fears, they have their social constraints, they have financial constraints. All of these things are important when we come to decision. And remember, we have to choose the most practical solution, which may not be the best solution, but if we choose the most practical solution, then it will give you some results. And what is the most practical solution, which has some medical validity, and it is also practically possible for the patient and family to carry forward. If you give them the best option, but they cannot carry forward with it because of their personal, social, financial issues, then the best treatment has no value because they just cannot carry forward with it. So participatory decision making is what is very important. Participatory decision making means the patient, the family, the medical team. Since many of you are nurses, and in many parts of our country, the nurses are not necessarily part of the decision making team, please understand that you have to be proactive because many a time the nurses may be better tuned in to the patient's social, financial, and other situations which the doctors may not be. And it is very important that if we work as a team, don't think that your job is only to carry out orders. It is also to give back information to your doctors so that you are in partnership in decision making. Because only if you come across important information that you pass on to the doctors, you and the doctors, the physiotherapists, the pharmacists, everybody works as a team so that then we team up with the patient and family together, everybody has a participatory decision making by consensus, that kind of decisions, that kind of management will succeed. So in the end, you just summarize whatever was discussed and then confirm the treatment plan. And before you close the interview, ask them, is there anything else that you want to ask after all the discussion? So usually you will see a smile come on the face of the patient and family when you ask this question in the end. Is there anything else that you want to discuss? Usually a smile comes on their face and they say, no, nothing more. Now this history taking, this can be 5 minute history taking, this can be half an hour history taking, this can be 1 hour history taking, depending on how complex the situation is. If it is something very simple, cough and cold, then it will take 5 minutes or 2 minutes. But if you do it in this format, it will enhance satisfaction. If it is something very complicated, advanced malignancy, terminally, it may take more than half an hour, sometimes 45 minutes or even an hour. But the format is the same. The time may vary depending on the complexity of the situation we are dealing with. And in palliative care, we usually have to deal with very complex situations, and hence sometimes we may take more time, but it is not necessary. It is not the quantity of the time which determines the satisfaction, it is the quality of the time that we have used which determines satisfaction. So when you finish the interview, you close the interview by leaving the door open. What does that mean? Many times I come across patients when I go for home care, they have an immediate problem. For example, they have developed some infection or something. So I tell them, why don't you contact your treating doctor? Or they may have had some fluctuation in BP or some cardiac arrhythmia or some problem with their blood sugar. And I ask them, why don't you contact your regular doctor? And many times I get an answer, but they told us to come back after 2 weeks, or they told us to come back after 3 weeks. But I said, that is fine, but that was then when you were getting discharged, or when the last time when you met, they told to come after 2 weeks or come after 1 month. But your problem is now. So why don't you uh, contact them? So I'm amazed that they said that they didn't know that they could do that. They didn't know that they could do that they could contact their doctor in between. So they were under the impression that they can contact only after 2 weeks or only after 3 weeks. Now, as healthcare professionals, we may think that is very stupid of them. Isn't that common sense? That if they have a problem now, then they should be contacting now. But unfortunately, people do not think like that. We healthcare professionals being in this field, we may think that is common sense, but it is not. And therefore, it is very important to tell them, okay, our next we can meet after 2 weeks or after 1 month. In between, if you need to contact me or anybody in my department, feel free to come in between if you want. Nowadays, I write it in the prescription. Report early if needed. And sometimes I may give some description also, report early if pain is not controlled, etc. So this idea that you can come and meet us in between also is something that we need to actively convey. So patients do not know that that is possible. And also give them a number. If you do not want to give your personal number, do not give your personal number, but give them some number, some department number, or some way of contacting somebody. And that is how you close the interview, by leaving the door open. That is, my doors are open for you anytime. And then you finish by greeting, make eye contact, smile, and say something that is locally the norm. So this way we finish the the short history taking 2.0. And the last slide, All of these things, active listening, is basically we are training ourselves to behave in an empathetic manner, not sympathetic manner, not feeling sorry for them, but trying to behave in a way where they feel that we are with them, that we are with them. So with them is empathy. We are here trying to be with them in our body language and the verbal choice of framing questions and asking things. Everything is giving them this experience that we are here with you, for you. And this is an experience that we want to give them because that is what gives them satisfaction. They may not remember many things, but they will always remember how we made them feel. And many a times that's the only thing that they remember. So remember, talk less, listen more, practice active listening. And what is active listening? A whole lot of positive body language and remembering the verbal do's and don'ts. So with that, I stop here. I stop sharing. In case you have any questions, I'll be happy to ask them, or uh, I will hand the baton back to our Talim India team. Thank you.
Participant, if you have any doubts, you can unmute yourself and ask, or either you could put it in the chat box also.
I think there are participants who have raised their hand. There is
It's
Fatima.
Fatima Sulaiman. Hello, Fatima.
I think there are more people who have raised their hands.
Kusum?
And there are some things in chat also. If there are any questions
Sir.
in chat.
Sir, there are some comments in the chat, no questions.
Okay.
Effective communication with patients facing progressive disease with complex problems and an uncertain future is a challenge and needs skills and practice. And good and effective listening with effective body language helps greatly in recognizing all the patient's problems. And thank you, allowed doctor, for this information. Considered history taking for the patient support psychologically and gather information to get correction data for patient. So such comments are in the chat box. There are no questions.
Oh,
I think Kusum have something to ask. Kusum, please.
Good, good evening, sir.
good evening. Good evening. Krishna. Tell me.
Sir, I had a query.
Yes, please.
Yes, sir. When we are breaking bad news with our patient, is there any special kind of gesture we should follow, and or some questions how you'll frame for our patient?
Kusum, we will talk about communicating bad news in our second session, communication part 2, where we will be talking about exactly these kind of things. We will be talking in detail on those things. So
Okay,
please
sir.
bear with me. We will not talk about it today because today we
Okay.
are focusing only on the basics.
Thank you, sir. Thank you so much.
Okay.
Mr. Rajesh, do you have anything to ask? Hello, Mr. Rajesh, you are muted. Mr. Rajesh?
Hello.
Yes, we can hear you.
Yes, sir. Good evening, doctor.
Good evening, Rajesh. Tell me.
Sir, just I want to ask, for example, a physically impaired persons having a hearing impairment of hearing, no? Those type of clients, how we can deal, sir, especially with the communications.
Oh, that's quite a challenge. There can be, today's session was to give a general idea
Okay,
about
sir.
that thing. Now, those are challenging situations. Then individual variations might be there. For example, if somebody can't hear, as you mentioned, if
Yes, sir.
that person is literate, can read and write, then you have an option, right? If that person has a hearing device and has forgotten it at home, asking the family to get it as early as possible because that is
Yes, sir.
needed, that is another option. And
Yes,
if
sir.
there is no option for a hearing device or writing and things like that, then there is this universal method of communicating, that is non-verbal.
Yes, sir.
You know, did you
Yeah,
have
yeah, yeah.
food?
Signal. Signal.
You know, the world famous Malayali headshake. This is one non-verbal communication, right? so,
Yes, sir.
so all of these things,
Yeah.
then we have to employ.
Yes, sir.
And in our country, the what do you call this? Nobody teaches us how to communicate with those who cannot hear. And as a result, those who cannot hear, until unless they are taught, they will not be able to communicate without knowing how that. And rest of us who are not hearing impaired, we definitely are illiterate when it comes to
Communication.
that kind of communication. So our population as well as the rest of the population are mostly not aware of the communication skills. So therefore, we have to manage with some kind of gestures. Sometimes it can get frustrating for everybody, the patient and the communicator concerned. But ideas persist. Find some ways of going about it. Sometimes you can draw pictures to try to understand what
Yes, sir.
is, it basically individual to individual, we may have to modify, somehow communicate.
And one more thing, sir, for a client having a palliative care, they may be in a severe depression. As we know, in depression, there is a lack of eye-to-eye contact maintained by the client. So in that case also, what we can do?
Yeah. So that comes when that improvement comes. See, remember one thing:
Yes, sir.
a person can be depressed. The person is not dead yet, right?
Yes, sir.
So there
Yeah.
is a still potential to regain that eye contact.
Yes,
Now,
sir.
where does that come in? One, if the person is clinically depressed, then we have to, medically manage that.
Yes,
Apart
sir.
from that, severe sadness, not amounting to clinical depression,
Yes, sir.
that also, we can use the word depression when we talk. So if it is not clinical depression, then it is our persistence with that person, spending time. That does not mean spending a lot of time, but you know persistence in our spending time, which will earn
Bond.
the trust, bond
Yes, sir. Yeah.
and trust.
Yes, sir.
Once they trust us, start trusting us, the body language will change.
Yes, sir.
Initially you will find that you go and talk to them, they don't want to talk to you, they don't
Yeah.
make eye contact, all of those things you will see. But if you persist with it, they'll finally realize that you mean well. You're not here to do some
We only read.
checklist. Yeah. So once
Yeah.
that comes in, you're able to break through into their psyche, they will open up.
Thank you, doctor.
Yeah, most welcome.
Doctor, for this wonderful presentation. I think we can move to the case presentation. There are.
I would like to thank all those people who sent wonderful messages, all the thanks message and all the compliments. It lifts up my spirit and makes me motivated to continue teaching. So thank you everybody for your wonderful response, and please proceed with the case presentation.
Yeah, happy to hear that, sir. We'll move to the case presentation. We have a case from Ms. Sarda Karpot. Sarda, can you present it? I can share the screen for you. Hello, Sarida. Sarida, can you unmute and speak yourself?
Hello.
Yes, ma'am. We can hear you.
Hello.
Hello.
Okay. Good evening.
Okay, yes, ma'am. We can hear you.
Good evening, ma'am.
Yes, ma'am. Please.
My name is Sarita Harper. My designation is staff nurse. Then my organization affiliation in Civil Hospital, Shillong. Next slide. Then patient details. His age is 48 years, gender is male, and the diagnosis is cancer of esophagus. History of illness. The patient is asymptomatic before 3 months. After 3 months, he started develop a symptom of esophageal cancer and went to and came to a facility to get himself treated.
Hello.
He was,
Hello, Sarita.
yes, yes.
Ma'am,
Yes, ma'am.
Ma'am, your voice is shaking.
Yeah, because of internet network, I think. Then has history of smoking, has history of esophageal cancer. Then he came to a facility on 15/2. Then no history of any surgical procedure. Next slide, ma'am. Next slide, ma'am. Hello.
Ma'am.
Hello. Yes, yes. I cannot see nicely the slide, ma'am.
Hello, ma'am.
Okay. I cannot see nicely the slide. Okay. History of illness. The patient is asymptomatic 3 months, before 3 months. After 3 months, he started to develop symptoms of esophageal cancer and went to a hospital and get himself diagnosed and treated. He had undergone the needed investigation. Then the biopsy on 23rd, the biopsy report on 23rd to 22 diagnosed with cancer of the esophagus. He was admitted recently to a hospital for the progress of the disease condition. Has history of smoking, had history of consuming alcohol, no history of allergic to any drugs, no history of allergy to any drugs, no history of communicable disease, no history of any surgical procedure. Next slide, ma'am. Examination. Physical and general examination. BP is normal. Pulse 92. Temperature is 99, slight fever. SpO2 is 95%. Patient looks weak and fatigued due to disease communication. Then his weight is 52 kgs. Height is 152 centimeter. Mild edema present in both legs. Mucous membrane looks dry. Then pain and auscultation crop sound was heard. Sound was reduced. No tenderness is present. Pain in the area was neck score is 7 to 10. Next slide, ma'am. Presenting complaint. Patient had the complaint of swallowing difficulty since 1 month. He had nausea and vomiting for 3 weeks. He had chest discomfort also for 3 weeks. Then pain during swallowing and unable to sleep properly since 3 weeks. Mild fever since few days. body ache since 3 weeks, constipation since 1 week, then came to a facility on 26 February 22. Next slide, ma'am. Treatment and significant investigation. Chemotherapy, radiation therapy, dehydration management, pain management, palliative therapy. Then the blood investigation was done. Hemoglobin was 11. Patient count is 4.3 lakhs. Then the urea is normal. Then creatinine is 13. Then the platelet count, the electrolytes is normal. Endoscopy done on 22nd to 22 reveals carcinoma of esophagus. And the CT scan also was done, revealed carcinoma esophagus with erosion and involvement of prominent of main thorax, bronchus. Medication he's getting, injection zone 1 gram IVBD 8 hourly, injection tramadol 50 mg with 100 ml NS 8 hourly, injection Pantam, then IV fluids, then in addition proper adequate nutrition assured as adequate dental care. Then he was advised to start chemotherapy on 27/2/22. Next slide, ma'am. Psychosocial aspect. Patient looks very weak. Patient also worried and scared about the disease condition, need assistance and support to the daily routine activities, inadequate knowledge regarding the effect of therapy, health education to the patient, and gain knowledge regarding the disease, health education for the condition of the rest of the disease. The focus attributed of the disease. Then plan after discharge. To follow up and home visit. Main concern, we have to concern about the generalized weakness, pain management, constipation, unable to eat orally, unable to sleep properly, dehydration, not able to socially associated again. Summary, we have to maintain the intake output, then continuous observation of the patient and monitor for any abnormal symptoms. Vital sign monitored when he is in the hospital every 2 hourly. Care taken of the catheter daily if the catheter is there. Care taken of all tubes which are inserted. Watch for respiratory failure. Daily assurement of pain. Counseling to the patient and attendant. Education about proper nutritional diet. The patient is still hospitalized. Plan for discharge with the advice to come for the next dose of chemotherapy cycle. Discussion points. How to provide education related with the disease condition to the patient and the relative is important in order to create awareness in them, how to give proper education and counseling about the treatment and reduce anxiety, provide adequate knowledge regarding the prognosis of the disease condition. Thank you.
Hello, sir.
Yes, ma'am.
Thank you, Sarida ma'am. And Dr. Biju.
Yes, please.
Yes, sir.
Thank you, Madam
Thank-
Sarita, for that excellent and comprehensive case presentation. I'm sure the audiences will have some comments or some questions to ask based on that case that you have presented. So it is open house. The all the delegates, please feel free to ask your questions regarding the case, and Sarita Madam will, hopefully answer to your queries. And if there is something that needs to be added, I will try to put in something from my side. So essentially, now this is basically your forum. This is something that a case discussion is about, discussing the case. You're all nurses, so one among you has presented the case. So it's up to you to ask questions to the person who has presented the case.
If you have anything to speak, please unmute and speak yourself. It's your turn now.
Hello.
Yes, Kusum.
Good evening.
Good evening, please.
Ma'am, actually for this like education part, madam, like this was very good case study. In that education related to disease for patient and their caregivers, then we have to like include all the component like good eye to eye contact, then like professional smile we have to follow, as sir already discussed in the seminar also. Okay, we should include all the component when we are discussing, like don't give false hope to your patient, and always keep open ended question for your like patient and caregivers. If you want to educate or always ask for question, like we have to follow these principle when we are discussing when we are discussing with patient and caregivers regarding their disease condition. And when we are discussing for like CA esophagus, then we should give like these are the medical options available and these are the treatment option we have, and like up to you, you can choose any of them.
Yeah.
These are the like comments.
Thank you for that, Madam Sarita. You kind of, you have summarized the whole thing very well. And if there are any questions, any further questions, we are running out of time also. If there are any further questions, feel free to ask. Yes, Madam Antonia
Antonia?
has put up her hand. Madam Antonia, you have a question. Please unmute yourself and ask the question, please.
Thank you very much. It's not a question, but there's another thing that I have seen is helpful to educate the family and the patient who has cancer of the esophagus. Some of them, they swallow a lot because when they swallow, it makes them cough, so they spit. So it's important to give them education of how they can safely get rid of the spittle, maybe a container which can be covered, and then they need to wash it properly with the disinfectant or soap and water. It's on that they spit, because when they swallow, then they cough and cough and cough. It is a challenge because it can be a source of infection for the family. So they have to be careful that the patient doesn't spit anywhere, but has a container for spitting in, and then they can dispose. Yeah, sometimes people like to put in soil in the container, but that is for in the community, so that it's not just, and then they put it away maybe in the pit latrine or something like that. So it's important to educate the family about where to Thank you.
Thank you,
Madam
Antonia.
Antonia. Thank you.
It's high time. I think we can wind up now. Is it okay,
Yes,
sir?
please. Absolutely, absolutely.
Okay, sir. Thank you so much for this wonderful class, and looking forward to have many classes with you again. Thank you so much. And all of you, thank you for being with us today. And kindly please provide the feedback. I have shared the link in the chat box, and I will be sharing it in the WhatsApp group also. So please do it. And thank you all once again. We'll meet you on the next class. Bye then.